prices are hidden, and consumers are left guessing what they're on the hook to pay.
When they ask for a price, we give them an estimate. Then we bill them whatever we want.
Involved on hospital pricing method, long implemented by hospitals and insurance companies to create unprecedented wealth.
Yeah, we don't do prices.
We'll send you a bill.
Involved on hospital pricing method, long implemented by hospitals and insurance companies to create unprecedented wealth.
Yeah, we don't do prices. We'll send you a bill.
With huge surprise bills later.
Overcharges, price gouging, and ultimately turmoil and crisis at home.
Estimated pricing with huge
How much is the ice cream?
Prices? No, we don't have those anymore. We have estimates.
Turmoil and crisis at home.
Estimates? How much is the ice cream?
Prices?
Behind me is a representation of American employers, unions, and workers, the very fabric of our economy. Together we stand against a healthcare system that hides its prices, rigged for corporate greed. Today, American workers and employers are desperate for prices and data in healthcare to protect against hospitals and big insurance companies, robbing their access to affordable care and honest billing. Without prices, all the money is stolen from every paycheck, bottom line. Without transparency in healthcare, Americans will never have access to the best care at the best price. So if we want to do right by American employers, unions and workers, and the families they represent, we need prices now. Now, to the patient.
We need prices now. Power to the patients.
Manny's going to want to stand there, so I want to be able to exit. You know what I mean? And just stand to the side. Good morning. Can we have people start to take their seats? We've got a full agenda and we want to get started. Well, my team never gets that quiet when I ask them to do that. That's amazing. So, good morning. We're going to go ahead and get started. We've got a very full day. I am Claire Brockbank, and I'm the Director of Policy and Strategy for the 32BJ Health Fund. Can you all hear me? Is that better? Yes. Okay. Thank you, Misha. So thank you for joining us for our third annual conference on hospital pricing. I see a lot of familiar faces in the room, which has been fantastic. It's a little like Old Home Week. We also have a number of people streaming, which we're hoping third year is charmed and that'll work beautifully. So thank you all for joining us. Because there are also a lot of new faces, I'm going to take just a minute. I'm being directed to move. Okay. I'm going to take a minute to give a little bit of context. So 32BJ Funds are a labor management organization, and we are governed jointly by the 32BJ SEIU Labor Union and many thousands of employers who are represented by the Real Estate Board of New York. We are a self-insured health fund. We provide well over $1 billion in healthcare services to our participants. And as we do that, we've learned several things that drive what we do, what we'll be doing today, and what we do all the time. And that is that despite maybe what the headlines say, it is not insurance companies and pharmaceuticals that are the primary driver of our healthcare costs. They are guilty, but the largest single driver, without a doubt, are hospitals. Their rate of inflation has gone up on prices at double the rate of everything else. We also know there are incredible disparities in price between one hospital to the next. and that there's no real correlation to quality in those prices. Where there is a very direct correlation is in market power, in market consolidation, and the ability to demand prices so that you can have a hospital next door to each other and one has more market power and can therefore charge higher prices. These same hospitals that are large and dominant also are able to enact some pretty anti-competitive contract clauses, if you will, with the insurers that we rely on to help set our network. And it is not all hospitals, it is just some. We do have many, many hospitals in New York and around the country that are working very hard to serve their communities and that are not exacting these kind of prices. So our focus is on a very specific segment of the population. We also know, and you'll hear today, that market consolidation is not just about hospitals. It's also, there's private equity coming in, and we see a number of independent doctors being bought up. And what happens when a local doctor is bought by a corporate system is that all of a sudden the service that the doctor provided at one price today can now be charged at a hospital price because they're at a hospital outpatient price because they're owned by a hospital. That affects all of us. And so those are some of the things we'll hear today. So today is about bringing forward a community of people to look at these issues of hospital prices and what we can all do about it. Our lineup is incredible. We have policymakers and regulators who have committed their careers and their efforts to these issues, and we're so pleased to have them standing alongside us. We will talk about a number of policy issues at the city, the state, and the federal level that we can all take and engage and support in that will help address these issues. We'll hear from a number of engaged and creative and determined purchasers who are doing some amazing things that every purchaser in this room should consider and could consider. They're no longer inaccessible, difficult strategies. We'll share some tools that we've developed over the years to help us get our arms around this problem and address our own benefits that we're really happy to share and make publicly available. So what is most important, though, about this conference, perhaps, is that we can all learn from each other and use this as a moment to gather our community around, to remember that the work we do feels sometimes immense against the power of an enormous industry. Remember, this is 18% of our economy, but that there are numbers. The numbers grow every year, and so this is a chance for us to refill our tanks and be encouraged and inspired to keep moving. So that's our day. A couple of housekeeping things. Lunch will be served on the 4th floor. We're also live streaming on the 4th floor, so if you need to step out to take a call, but you want to keep a half an ear on the proceedings, that's going on the 4th floor. Bathrooms on both floors. Wi-Fi information is up there, and I believe that's the core of our logistics. We will make slides available for most but not all of the speakers after the conference. So before jumping in, though, I want to, 2 years ago, almost to the day, we put our first conference on. And it was a very small but mighty team that put that first conference on. This is our third. It's grown every year, as has my amazing staff. And between the staff of the Policy and Strategy Department and a number of amazingly loyal fund volunteers, they've worked tirelessly to put this event together for everyone. So I'd like to just take a moment for you all to thank them as I thank them for their work. It really is an amazing team. But now it is my pleasure to introduce a man who I admire enormously, Manny Pastreich, who is the head of the 32BJ SEIU union. He's been with the union for over 20 years, and he started as director of research and has made his way up through the ranks. He's also the co-chair of the Taft-Hartley that governs all the fund's work. Manny recognized early the impact that healthcare prices have on a successful collective bargaining outcome. He was the primary bargainer for the union for many years. And unlike many, he was motivated to work with others to determine what it was that was driving it. And once it became clear the central role that hospitals played in this, Manny was one of the visionaries that said, what do we do about it? And he brought that union mindset that this is a long, hard, sustained effort, but that we are going to do something about it. So as Manny assumed the presidency of the union, we are so deeply grateful for his continued support and commitment to this, and we will continue working on this under your leadership. So thank you, Manny.
All right, thank you. It's great. We're really, really glad you all are here today. This is such an important thing. And I actually want to start, everything Claire said was really, I want to start by thanking her, because when Claire showed up along with Corey, along with our health fund director, Cora Opshall, Misha Sharp, our fund director, Peter Goldberger, and their whole team, which I can't name, we really went from a position where we went from complaining about healthcare to doing analysis on healthcare, to coming up with policy solutions, to actually taking action. And without the team that is really behind it all, because I can guarantee you it's not me, we would not be where we are today. So thank you all. Let's give it up for them all one more time. And in that vein, we are not, and I'm going to say this a lot, this is not something we can do by ourselves. We're dependent on the policy, on legislation, and government action. And so we are so happy to have in the room today a lot of people who can make those kinds of things happen. Starting with New York City and State, we have representatives from the New York State Department of Labor, the New York City Department of Health and Mental Hygiene. We have State Senator Liz Krueger, State Senator Holman Siegel, State Senator Julia Salazar, State Senator John Liu, Assembly Member Manny de los Santos, Assembly Member Yudelka Tapia, former Assembly Member Richard Gottfried, and then Councilmember Lynn Schulman, Councilmember Julie Menon, Councilmember Carmen de la Rosa. And then from New Jersey, we will have Assemblywoman McCoy and Newark Mayor Ross Baraka with us today. So let's give it up for all those folks who can really help us make this difference. And then finally, in the thank you department, I just want who you'll hear from as well, Howard Rothschild, who's the president of the Realty Advisory Board. And along with him and the employers, this is something that we do in cooperation. It's one of those rare but very positive partnerships between management and labor that has been really working. So we thank them for their partnership and leadership. So, why is a labor guy standing in front of you talking about hospital pricing? I ask myself that question all the time. We are a union of 175,000 service workers up and down the East Coast, about 90,000 of them here in New York City. Our members are janitors, security officers, residential workers, the airport workers who come on the plane as you get off to clean them, push the wheelchairs at airports, and so many other the essential workers who make New York City and New York State work. And the part I do know is that our union members' collective strength has lifted them out of poverty, but I also have come to learn that healthcare is what's going to force them to struggle every day to live in New York City. And I say this even though our members pay no premiums, they pay no deductibles, and they have minimal co-pays. So why is it that healthcare is this big threat? Over the past decade, until this last round of bargaining, half of all the compensation increases that we bargained very hard with Howard and the other employers, half of all that money that we bargained went to healthcare. Didn't go to wages or other benefits. It went to just maintain our health program. And this is largely because of hospital prices. We're now paying more to the top 5 hospitals in New York City than we pay for all the retirement benefits together for our members. If hospital prices had simply kept pace with inflation over that last decade, our members would have another $5,000 in their pockets, which is a real difference for someone who makes about $50,000 a year and struggles to pay rent and groceries every day. So that is why, as Claire said, we took on this fight. In 2018, we took to the streets for the simple right to be able to tell our members that which hospitals were the most expensive, and the right to encourage them to use other high quality but more affordable hospitals through copay differentials. And just as one example, the 32BJ Health Fund created a maternity program composed of the highest quality, low-cost providers where members would not pay 1 penny out of pocket to have their babies. We encouraged our members to use the maternity program so they could have that high-quality prenatal care, that postpartum care at these top-notch hospitals. But then in 2021, New York Presbyterian tried to require us to change the health fund's plan design that would have prohibited the health fund from maintaining its non-preferred copay structure, which is our mechanism for guiding members to the best in both quality and value. We were not going to bow to that, and this was a deal between the TPA and the hospital that we had no say in. But we said we can't bow to that, and we went to the streets for the second time, and the way we resolved it is the health fund wound up reaching an agreement to exclude New York Presbyterian from the network. And I have to say that was a very hard decision. Number one, New York Presbyterian has great quality. Our members loved going to New York Presbyterian. And I will say that, we are not in any single way critical of any of the doctors, the nurses, the frontline folks. They are the best here in New York City. Our members love them, we love them. This is a fight we have with the executives and the accountants who comes up with the pricing. Our members love the location of New York Presbyterian. Tens of thousands of them live right in the New York Presbyterian service area. And over 20,000 of our members had gone to New York Presbyterian in the previous 2 years, so this was very disruptive to our members. But as a nonprofit institution receiving hundreds of millions of dollars a year in tax breaks, it should be a place our members can rely on. But the health fund could not bear the outrageous prices charged by New York Presbyterian, and the health fund would not alter its plan design to suit New York Presbyterian's business model. So these fights helped the health fund dramatically reduce its spend, and as a result, we negotiated the largest wage increase ever for our 50,000 members. We increased their pension benefit by 10% and provided a health premium fee holiday to the employers. And that was a result of the dramatic action we took to get those great contracts. If we had sat back and let the tens of millions of dollars go to these overpriced hospitals, we would not have gotten that deal, and a strike would have been likely. So that was a key moment for us. At last year's conference, we talked about how some of the innovative work we're doing to take on the best practices from across the country, and actually from many of you that are in this room today, as we bid out the TPA work for our 200,000 covered lives. The Health Fund initiated a year-long RFP process searching for a third-party administrator that could partner to control our health fund costs. Despite our preparations, the Health Fund unearthed part of the process. What we unearthed was not pretty. First, it was nearly impossible to get meaningful information about hospital pricing that the TPAs had said they could give us. Second, we did gain unprecedented visibility into the restrictive contracting terms between the TPAs and the hospitals, that hurt purchasers like our health fund, but are widespread in the industry. And then third, the health fund found only one other TPA, other than the incumbent, who claimed they could keep Presby out of our network so we could retain that tens of millions of dollars of savings that we had had. So we went through the thorough analysis. The health fund trustees made the decision to switch to Aetna, a decision we believed would have saved, again, an additional tens of millions of dollars. But then the trustees were suddenly told by Aetna, just as the contract negotiations were literally at the last seconds, that the health fund would have to pay New York Presbyterian $25 million or Aetna could not keep them out of network. We were unwilling to pay this baseless demand, and under time constraints, we returned to Anthem, the only provider in the market who claimed they could still exclude New York Presbyterian. But now, literally just a few months later, we find ourselves in the same situation as Anthem and New York Presbyterian bargain their contract, again, where we have no seat at that table, and they're saying that New York Presbyterian is trying to force us back in without our say and our ability to have any control over that. And that could happen at the end of the year. And again, if that happened, we would be paying tens of millions of dollars that we used to save and get the good contract that we had. But this is 32BJ, so we don't do things without a fight. The union and our joint public education fund are telling the facts. There's actually two great articles today, one in the Albany Times-Union and another one in City and State. We're out in front of New York Presbyterian with billboards, with moving trucks, and probably more importantly, in the coming weeks, we'll be out in front of New York Presbyterian with our members who really understand and believe that this is not something that's acceptable. So we're confident that we're going to win this fight. Now, everything I said, you might ask, why are we confident that we're going to win this fight? First, while we recognize that healthcare is incredibly complicated, our demands are not. The health fund's purchasing literally billions of dollars of services and should be able to negotiate for those services in a free market. Seems like a good concept. But we're in an opaque system where prices are hidden and contracts are negotiated between hospitals and insurance companies with secret terms benefiting a handful of powerful players. But we truly believe that there's some might in right. Second, we're not in this fight alone. We, in addition to all the incredible policymakers and legislators we have in the room today, we have a great coalition in our coalition of affordable hospitals. We have DC 37, United Federation of Teachers, the Public Employees Federation, the Community Society of New York, the New York Immigration Coalition, the NAACP of New York, and the Buffalo Black Nurses have all been standing with us, and it has been a powerful coalition to get things done. And third, we're making concrete progress. New York City is the first city in the country to create the Office of Healthcare Accountability under the leadership of Mayor Adams and Councilmember Julie Menem. We estimate that New York City purchasers of healthcare, the city itself could save $2 billion a year if they just paid Medicare rates instead of standard commercial rates, money that obviously is critically needed for city services. And what's more, high hospital prices represent a hidden tax on all New York City businesses, and we're going to hear a lot about that today. Number four, we have a plan to move forward. Our states are on the move. In New Jersey, we've introduced legislation that'll codify hospital price transparency and provide teeth to New Jersey's Office of Healthcare Accountability and Transparency so that government, employers, and consumers can make more informed choices on healthcare spending. And as we look ahead in the legislative session here in Albany, we're very excited to partner with Senator Krueger and Assemblymember Jackson and our allies across New York to introduce groundbreaking legislation that further addresses rising hospital prices in the state. And again, you'll hear more about that today. And then finally, and most critically, we're really encouraged that federal enforcement agencies have taken a sharp interest to ensure that hospital markets remain competitive and responsive to consumers. That's evidenced by the DOJ, the FTC, HHS, and the White House National Economic Council, and we're excited to have speakers from some of those agencies here today. So, again, I thank you all for coming today. This is incredibly important work. Together we can get things done. And with that, I'm now going to introduce Ryan Danks from the Department of Justice. And that talk about the importance of federal attention to this is a nice transition to Mr. Danks. So, Ryan Danks is from the U.S. Department of Justice, Antitrust Division, and he's going to start today's important conversation. Ryan is Director of the Civil Enforcement and he was formerly the Chief of the Washington Criminal Section of the Antitrust Division. He has 20 years of experience in the healthcare area. Ryan previously served as Assistant Chief, as counsel to the Assistant Attorney General, and as a trial attorney responsible for prosecuting cartels and official corruption. He's litigating merger and non-merger civil enforcement actions now. So please welcome Ryan to the stage.
The one thing that I should have included in that bio is that the very first case that I signed, the very first complaint I signed as a trial attorney 18 years ago, was a lawsuit against a group of hospitals in the state of Arizona for suppressing wage competition for temporary nursing services, per diem and travel nurses. And so I have in fact seen for a long time the importance of competition and the dangers of consolidation or coordination in the hospital space. Thank you, Manny, for that very, very kind introduction, and to 32BJ Health Fund for inviting me to share some thoughts with you this morning about the importance of healthcare competition, the importance of choices for patients and workers, and what we can do to help markets create those choices in the face of dominant, entrenched hospitals and insurers. I will say that my remarks this morning are my own and do not necessarily represent the views of the Department of Justice. The stakes of these conversations are obvious. Patients and their families seek healthcare when they are most vulnerable: birth and death, life-threatening illnesses, chronic diseases, traumatic injuries. Nearly 18 million workers gain work and satisfaction through helping to care for patients. Because our healthcare system is based on properly functioning markets, these patients and workers depend on competition to deliver lower prices, higher pay, greater control over their care or working conditions, and better outcomes. Patients and workers benefit when they have choices. And despite doing our best with limited resources, the status quo does not serve those patients or workers. Undue market concentration and a loss of competition plague every stage of healthcare delivery. And the thing is, everybody knows it. Physicians and hospitals complain about insurer consolidation. Insurers complain about hospital and provider consolidation. Workers recognize that they have fewer choices among healthcare employers. And consumers know that they face rising prices, less generous health insurance plans, and fewer choices. And the thing is, they're all correct. From our largest cities to our smallest towns, Americans face healthcare markets where they have too few choices and not enough meaningful competitors. Almost half of all metro areas are dominated by a single health insurer, and far more are highly concentrated, as we antitrust nerds say. The markets for hospitals and physicians are similarly concentrated, if not worse. These market structures not only give single insurers or single hospitals too much control over patients and workers, but they also make it easier for the remaining firms to informally cooperate with their would-be competitors to raise prices, reduce wages, hamstring benefits, or limit innovation. Some even have a word for it: co-opetition. The thing is, we know that this consolidation is no accident. Lip service about the value of integration aside, and I'll address that more fully in a minute, everyone knows that the trend toward consolidation up and down the value chain is focused on promoting market power. Even worse, hospital consolidation feeds insurer consolidation, and vice versa. Market participants are trying to outrun each other or the government payment programs in a never-ending quest for bargaining leverage. This isn't rocket science. There's $4.5 trillion that we spend every year on healthcare that's at stake, and that money provides plenty of incentives for large companies to grab as much of that pie as they can. As too many workers know from painful experience, this sort of consolidation leads to brute force negotiation tactics that aren't efficiencies in any sense of the word. They don't reduce costs, they don't improve quality, they don't lower prices, and they don't increase pay, lead to greater innovation, or otherwise improve outcomes or working conditions. Instead, they are naked attempts to throttle competition and grab as much of that pie as they can. The results are equally obvious. Americans pay more for care than any other industrialized nation, and those higher costs don't lead to better outcomes. We have seen the obvious ways that the loss of competition harms patients and workers, higher prices and lower wages, how major players don't compete as hard because they don't have to, and how contract restrictions limit the free movement of patients and workers. But if we look more closely, we can also see less obvious symptoms of missing competition. Less innovation on pricing and care models, less pressure to provide transparent, predictable pricing, and fewer chances for insurers and providers to use data to help improve outcomes. There are no easy answers to these challenges. As we have seen in other areas of the economy, it is difficult to unwind a long trend toward concentration, which is why we as enforcers must be vigilant about stopping those trends and closely scrutinize agreements and practices that discourage new challenges to dominant incumbents. We applaud and encourage new organizational forms that improve care and reduce costs. But we do not give a pass to sham arrangements that entrench market power and restrict competition while posing as improvements. Because in the end, regardless of how an organization is structured or how payments are arranged, competition is essential to make the healthcare markets work. This brings me back to mergers or other agreements that promote vertical integration. No one disputes that there may be value to closer coordination among the different parts of the value chain, including improved care and patient convenience. Nor should we necessarily discourage efforts to align incentives within that value chain and promote patients' ability to make choices outside of it. But we should also recognize that vertical integration in already highly concentrated markets can reduce competition. That integration makes it difficult for new competitors to gain a foothold in markets up and down the value chain. Consider a city where a dominant hospital must negotiate with a dominant insurer. Each should have strong incentives to promote alternatives to the other. The insurer should want its insureds to have meaningful choices among hospitals and specialists. And so it has every incentive to support entry or expansion in various ways, including by guaranteeing volume to ambulatory or outpatient surgery centers. So too, the dominant hospital should want to sponsor entry or expansion by competing health plans, including by offering greater discounts that promote their growth. But consider how those incentives change if the hospital and insurer are vertically integrated. The insurer doesn't want other hospitals competing meaningfully with its hospital, nor does the hospital want other insurers that compete meaningfully with its insurer. So meaningful competition to both would be shut out. And that's a problem. Firms that face threats from competition have the incentive to improve their operations for the benefits of patients and workers. Firms that are insulated from competition don't. Besides closely scrutinizing mergers and other agreements among physicians, hospitals, and insurers, what more can we be doing to preserve competition? In a few of our largest cities, we still have a chance to protect competition and choices in the traditional sense. If a hospital or physician group doesn't want to compete for a patient's business, then they can choose to go elsewhere. But in most cities and towns, such choices are an illusion. One-hospital towns offer no choice at all. Even cities with a few hospitals are susceptible to that co-opetition I mentioned that frequently plague highly concentrated markets. So we need to think about other ways to promote competition and allow markets to offer new choices for patients and workers. We need to make sure that dominant hospital systems don't use contracts, affiliations, or vertical integration to cut off competition. Independent outpatient centers and other alternative providers should be empowered to provide competitive alternatives. Dominant hospital systems should not employ every doctor in town, especially every specialist. Telemedicine and remote care options, especially for preventative or chronic conditions, should be encouraged. And patients should always have easy and consistent access to their medical histories so that they can seek out alternatives with minimal friction. And markets should permit new kinds of companies to emerge that help steer patients through non-traditional and innovative provider networks. We must also find ways to let competition and choice promote transparency and predictability in prices. It is hard to imagine a more significant life purchase with prices that are more opaque and harder to compare. That opacity makes it easier for large companies, especially vertically integrated ones, to turn unseen dials and levers to extract more money from patients. That opacity makes it possible for providers to saddle consumers with incomprehensible, incorrect, and untimely bills. And that opacity frustrates efforts to incentivize consumers to make choices that impose some kind of pricing discipline. In this instance, the lack of competition means that there are imperfect tools for doing so today, and that there's not enough companies out there with incentives to try to change that fact. Finally, please remember that when patients, their advocates, and employers and other plan sponsors have choices, they must be willing to make them. If every hospital and every insurer is a must-have, then there will be little that markets can do to discipline any exercise of pricing power. Real competition will only occur when such choices are available and when they are being made, or at least credibly threatened. Now, over the last several minutes, I feel like I've done a better job of identifying challenges than describing solutions. So I want to mention one more. Whomever said all politics is local had clearly never been involved in healthcare delivery. Because then they would have truly known what local markets are. Patients must have access to healthcare where they live and work. And because we can seldom predict when that access to that care will be most needed, it is hard for those patients to give up the chance to access local care in exchange for something less expensive much farther away. Which means that across the country, there are not just dozens, but hundreds and perhaps even thousands of relevant geographies in which there are opportunities for corporate mischief and the exercise of market power. That is a lot of ground to cover in every sense of the word. More than 75 years ago, the legendary antitrust enforcer Thurman Arnold spoke in ways that resonate with this challenge. He talked about how the first 50 years of antitrust enforcement had been a series of crusades that were more concerned with the dramatization of an ideal instead of continuous enforcement of cops on the beat, and that the vast mine run of offenders are permitted to go their way unmolested. Although I had to look up what mine run meant, I think his gist is clear. We cannot preserve competition without taking a systematic approach to enforcement. In Arnold's words, to have a police force adequate to accomplish meaningful economic results, not just in a handful of large cases, but in the county by county, metro by metro area work across the country. One step the division has recently taken toward this end is the formation of the Task Force on Healthcare Monopolization and Collusion, led by my deputy, Katrina Rouse, which brings together civil and criminal prosecutors, economists, healthcare industry experts, technologists, and others from across the division to work closely with our partners throughout the federal government to tackle competition issues in healthcare. But the division cannot, and our colleagues at the FTC cannot do this work alone. Through the task force, we are looking to build partnerships across the federal and state agencies that provide oversight and funding to these important markets. We will continue to look, as we have done so often in the past, to our partners at the State Attorney General's office. And here I want to pause for a minute and acknowledge the New York State Attorney General's office, led by Eleanor Hoffman, who has been an invaluable partner to the Antitrust Division across a range of enforcement efforts over the years, including in the healthcare space. We must recognize also the role that private enforcement and consumer advocates can play, whether by patients or workers, companies or unions, in ensuring that all the actors in the healthcare space respect the antitrust laws and the role they must play in promoting competition. So thank you again for the invitation to join you. Although I have painted a bleak picture of the state of competition in our healthcare system, let me close on a more positive note. We all have experiences with friends and family whose lives have been saved or transformed by the passion, commitment, and skill of healthcare workers. Those experiences reflect the promise of the American healthcare system, and it's our job as antitrust enforcers to do our best to ensure that those promises are kept for patients and workers throughout the country. Thank you very much.
Okay, am I live? Yes. Thank you so much. That was fantastic. We have just a couple minutes for some questions, which I will be posing to Mr. Danks. I guess the first question, you mentioned the importance of maintaining competition in local markets and the ability of purchasers and individuals to be able to set where they go. You heard also from Manny's opening remarks the challenges we're having with New York Presbyterian. In light of the Atrium case, which was, I don't know how many years ago, where anti-competitive, all products clauses, anti-steering clauses were overturned, if you will, why do you think we keep seeing this kind of action happening, not just in our market, certainly, but in markets around the country?
Sure, I think that's an interesting question, and I want to be clear that when I'm answering it, I'm not going to speak specifically about the situation here in New York or about any other particular market. I think that what we face here is a challenge where each hospital system, each dominant hospital system, has enormous incentives to maintain that dominance. And the ability of them to do so through the use of things like all or nothing contracting, anti-steering clauses, anti-discounting or anti-innovation clauses, gag clauses, most favored nation, there's a whole laundry list of tools in the toolbox. And unfortunately, the incentive to do so outruns the ability of the enforcement agencies to keep up with every instance where it happens. And so I think that's why it's important for us to pick our spots where we can to try to bring enforcement actions like we have against Atrium, which they ultimately settled and stopped using the clauses after we won on the motion to dismiss. But I think it's also why, as I suggested in my remarks, that we need to keep the pressure on, not just through the federal enforcement agencies, but through our enforcement partners and other players, because there's a lot of mischief that monopolists can make, as we've seen not just in healthcare, but other areas of the economy as well. And their ability to exercise those tools is always going to be there. They're always going to have the incentive to do it. And so it's up to us to try to keep the pressure on them and convince them that ultimately it will be too costly. But it's definitely a challenge.
Thank you. You mentioned the importance of all of these different stakeholders getting engaged, and we were heartened to see the task force that was created and the effort to seek input. Can you share a little bit about how that's played out and what you're seeing and where you see that going? And for maybe you mentioned it, but 2 seconds on what it is for those in the audience who aren't as familiar.
Sure. So for those of you who haven't had a chance to get familiar with the work, the task force is basically a combination of enforcers from the division and the Federal Trade Commission, along with our partners at the Department of Health and Human Services, that are working together to try to tackle issues of competition in healthcare in a sort of a multi-dimensional way, looking at just not only enforcement, the traditional enforcement efforts, but other things we might be able to do with respect to policy development, filing statements of interest or other interventions. And it's been, I think, very well received so far. It was launched just in March of this year. Since then, or around the same time, we put out a request for information looking for comments on consolidation, particularly among providers. And so far, I actually got these numbers yesterday from Katrina. We have more than 6,000 comments that we've received and that we're in the process of reviewing right now. And so we're looking for trends. We're looking for areas that are maybe issues or challenges for patients or workers that we weren't familiar with previously, so that areas that we should be focusing on in the future. And we're also looking for opportunities to build relationships with state and local governments and folks who have interests in this area from a regulatory or enforcement perspective. And so there's a lot of great work going on there. It is an enormous challenge, as I don't have to tell anybody who's here today. But the opportunity to do good is there as well, because there is so much money at stake and there are so many lives that are affected by this that I think it's well worth the investment of resources that we're making, and we're hoping to see some good results.
Thank you so much. And for those of you, that site is still open, and we encourage you to go in. It's very easy to register your experience and your perspective. And if you need help finding it, reach out to one of us at 32BJ Health Fund after the conference, and we'll help you out.
I should say we don't always do marketing well as a federal enforcer, but if you go to healthycompetition.gov, that will lead you to the Antitrust Division's website that houses our efforts in this
Wonderful.
area.
Thank you so much, Ryan Danks, for speaking.
Great. Thank you.
Okay, we're getting ready for our keynoter, but first I want to acknowledge we had some special friends come in. Senator Gustavo Rivera has joined the group, as has Senator Brian Kavanaugh, so thank you so much. I'm not seeing you, but for joining our ranks. Again, another indication of the importance of this issue at such a broad level in New York. So thank you very much. So it is my, oh good, I do see him. It is my pleasure to introduce Zach Cooper, our keynote speaker. He is the Associate Professor and Director of Health Policy at Yale University. And Zach's research is incredibly multifaceted. It covers many, many dimensions of healthcare. It's all very data-driven, which is near and dear to the heart of all of us at the 32BJ Health Fund, because we're data nerds deeply at heart. His work has looked at the causes of surprise bills, the impact of electoral politics on healthcare, the impact of price transparency, a very broad perspective. But the groundbreaking research that came out recently is one that is super important for everybody in this room. His team looked at the negative economic and societal impacts of hospital consolidation in local markets. Now, you heard Manny say this morning that our members would have $5,000 extra in their pockets if hospital prices had just stayed even with inflation. That's a number we use and calculate, but to see the work really actually quantified and analyzed at a broader level is such important work, because one of the arguments we hear often from hospitals is they're so important to their communities, jobs, security, et cetera. And in many cases that's true, but not in all cases. And as we see consolidation, increasingly less so. So without further ado, I introduce Zach Cooper to share his thoughts. Zach.
Got here eventually. Good to see you. Well, good morning, everybody. Put my water. I had to give Cindy a hard time. I asked for a purple 32BJ shirt, and she wouldn't give me one. So hopefully after I'll get one. So, healthcare is deeply personal, right? We rely on it at our most vulnerable, but it's only useful if it's affordable and it's accessible. So historically, most of my work has been thinking about what drives health spending up, right? What's causing health spending to go up over time? What's causing it to vary? Things like consolidation between hospitals. What are the effects? And these days, I'm focusing much more on how rising healthcare spending is affecting workers, their wages, their employment, economic inequality, and our ability to live lives of dignity and purpose, right? And increasingly, I think that rising healthcare prices, I'm going to show you today, is actually sort of underpinning a lot of the biggest challenges we're actually facing socially. What I'm going to show you is that there's a direct link between prices in the healthcare sector and jobs for those outside the healthcare sector. Right? That when prices go up, in this case from hospital mergers, jobs for workers earning $30,000 to $80,000 go away. Right? And I want to start by talking about the elephant in the room. Right? There are leaders from hospitals and health systems here. Anybody here from a hospital or health system? Oh, then you're there? Okay. Right. One person. I don't have to worry about that much. No, but genuinely, we need hospitals. Right? And we need them to be functioning. Right? Nobody's calling me at 2 a.m, right, needing emergency care. The challenge is how we differentiate from mergers that don't pose challenges for the community, right? Hospitals that are big because they're good, and mergers that are lessening competition and leaving us worse off. So what I'm going to do is speak for about 15, 20 minutes. I want to walk you through the new research. I want to talk about what it means for public policy, and then we'll open it up to Q&A. Right? And my goal is to think about how the work we're doing can sort of feed into the work that folks in this room are doing to try to make the health system work. So I want to just start with the question that I actually start with for all my students. what are the average premiums for employer-sponsored health insurance for a family of 4 in the US? Anybody know them? Bingo, $24,000. And I anchor it with this, right? The price of a new Toyota Corolla is $22,000. It's actually not a bad car. I went and test drove it. Literally, I've been using this slide so much that it was like, I have to go test drive a Corolla, and it was like pretty good. And the offshoot is that we've got basically every working family in the US buying a new Toyota Corolla worth of health insurance every year. It's sort of staggering to think about. And 2020, this was the work or a book that really shifted the way I thought about healthcare spending. So Ann Case and Angus Deaton. Angus won the Nobel Prize. And they wrote a book called Deaths of Despair and the Demise of American Capitalism. And what they wrote is that the US healthcare system is a wrecking ball, destroying the labor market for less educated workers. And truthfully, I didn't totally buy it, right? This book is what motivated a lot of the research that I'm going to present. And at the core of what they've argued, and it turns out they're right, is that because the majority of folks in the US get their health insurance through their employer, there's a link between what happens in healthcare markets and what happens in labor markets. Right? When employer-sponsored health insurance becomes more expensive, it directly affects workers. Now, there are lots of things that become more expensive, right? We know that all too well right now, right? But when the price of, let's say Mars and Hershey's merge, and the price of M&Ms go up, right? We don't think it affects jobs, right? Annoys me because I like M&Ms, but we don't think I'm going to lose my job. The reason that rising health spending and employment is so different is because of employer-sponsored health insurance. When it becomes more expensive, premiums go up, it becomes more costly for workers or for firms to keep workers. Right? And we often think that when benefits go up, it's actually paid for by workers themselves. That's actually what the evidence shows. Right? So if you introduce new maternity benefits, workers' wages go down, and in some ways that makes sense, right? It might be things that workers value, it's just a different form of compensation. But a lot of the spending growth of the last 2 decades in healthcare is being driven by things that we don't value. Right? Surprise medical bills, right? Upcoding, price increases for the same unit of care simply because the merging parties got more market power. The other, and this is super important, is that it's one of the leading sources of economic inequality, which is sort of wild to think about. Right, the way we finance healthcare in the US is contributing more to inequality than trade, than outsourcing, or lack of growth in minimum wage. And that's because if we look inside companies, right, the CEO makes a lot more money than the person in the mailroom. But it turns out their insurance premiums don't really vary that much. Right? And so when the cost of healthcare goes up, it serves as a very, very regressive head tax on workers. It's proportionally much more for the person in the mailroom than it is for the person in the C-suite. So what we've done in this work is tried to trace out the impact of price increases from hospital mergers, right, through to health spending, to insurance premiums, to what happens in labor markets, and then ultimately to federal income tax revenue. Right, so how do price increases from hospital mergers basically affect employers' employment and the wages of workers? And we're going to focus on hospitals, and it's kind of like why people rob banks, right? It's where the money is. And if we look at prices in the hospital sector over the last 2 decades, they've grown more than prices in any other sector of the economy. Sort of wild to think about. Now, there's like a or a pot calling the kettle black situation, right? College tuition is the number 2 on the list, but we'll just pick on hospitals for the moment. Right? Sort of staggering to think about. And one of the leading sources, one of the leading drivers of this price growth has been consolidation, right? Just merger upon merger in the hospital industry, sort of 40 to 100 of these transactions a year. And this is from a paper that my colleagues and I had earlier this year. What's super important to keep in mind is that not all mergers are problematic. Right? And I actually think we're much more effective as a group talking about this when we acknowledge the subtlety. Right? There are shades of gray. And the DOJ and the FTC actually have merger guidelines. There was a set released in 2010, a new set released late last year, that comes up with rules. Right? A change in concentration of this amount, right, 200 points in 2010 is now down to about 180. If a merger does that and makes a market concentrated, their sort of guidance is this lessens competition and raises prices. And what we found in this work was that about 20% of the deals that were allowed to go through were in that DOJ FTC red zone. Right, so there are about, on the order, 10 or 20 mergers a year that are lessening competition and raising prices. And so the way you want to think about what's happening is kind of like death by paper cuts. Right? It's just this sort of slow and steady accumulation of market power. And at the same time, over the last 2 decades, the DOJ and the FTC have gone after 13 mergers. Right? So 1,000 transactions, 250 or so that we think are really, really bad, 13 enforcement actions. And it isn't because the DOJ doesn't and the FTC know what's happening. It's just in a sense because it's really costly to do this. It's really challenging. And there is some deterrent effect, so they can't go after everyone. And the question for us at the end is going to be, well, what do we do? When there are constraints on enforcement, how do we move forward? So what we've shown in our work is it turns out the ones we predict that are bad, using the rules from the FTC and the DOJ, these mergers, these are the ones on the left, do in fact raise prices. Right? We can predict them. Right? And when mergers that are problematic occur, prices go up by sort of 5 to 10% over the next year or two. In the 80% of mergers where the market doesn't become less competitive, nothing really happens. And so what we want to do is trace what happens when these mergers here occur. Right? How does this affect the ability of workers to live lives of dignity and purpose? So we're going to bring together amazing data. I've got this roster of hospital mergers that I've been working on for years. We're going to get claims data from 3 of the 5 largest insurers in the US. It's going to cover about 30% of individuals in the US with employer-sponsored health insurance. We get data on insurance premiums from the Department of Labor. And I worked with an amazing group of economists at the US Treasury and the IRS who have a program to work with researchers to use tax data. And it's a formal program, lots of security, but it gives us access to the universe of tax returns from the IRS. So we can really see what's happening in labor markets. Now, I don't see the data, right? It's something that the folks at the IRS and Treasury do, but we get a really granular sense of what's happening in people's lives. So let's start, right? When hospitals merge, about 20% of the transactions lead prices to go up by sort of 10 to 15%. When prices go up, it's passed through on a dollar-for-dollar basis into insurance premiums. We actually don't see benefits get cut. Right? And that's really, really important for us to talk about. Right? I was reading in the material from 32BJ, right? It's, I think, 100% actuarial plan. Right? And so when prices go up, you're not responding by cutting benefits. And so the question is, how do these costs get paid for? Right? Care is more expensive. Generosity stays the same. What do we do? So again, imagine a firm was giving me parking. Right? Yale does it. Right? They pay for my parking. They're not really paying for it. They're just taking it out of my wages. And I'm sort of cool with that because I value parking. Right? It'd be a pain if I didn't have a parking spot. But what happens when the cost of my care becomes more expensive, but the care stays the same. Right? In theory, we don't think that workers value that. And what we're showing here is, for firms, we see that a 1% increase in healthcare prices is lowering the count of workers that firms employ by about 1/3%. That's actually a lot. That's a ton. Right? A 1% increase in prices in the healthcare sector is lowering employment at firms outside the healthcare sector by 1/3. Now, part of the reason that effect is so big, and it might not seem that big, is because when my prices go up, or when the prices locally go up, it isn't just affecting me. Right? It's potentially affecting my wife, kids, right? Because there are lots of folks on my insurance plan. Right? So there's this sort of multiplier effect going on. So people are losing their jobs. And one of the things we tried to tease out in this paper is it's just simply folks losing their jobs and finding other employment. Right? And the answer is no. Right? So we look at the number of folks who get unemployment insurance locally. Right? And that goes up. So a 1% increase in healthcare prices is going to reduce income per capita by about 0.3%. It's going to lead to job losses, a 1% increase in the number of people on unemployment insurance. It's going to decrease income tax revenue. It's going to increase state spending on unemployment insurance. This is like the worst kind of public policy. Right? It cuts jobs, it lowers tax revenue, and it raises government spending at the same time. This is the kicker. Right? What we could do with this data is separate out who the people were who were getting affected. Right? And again, theory tells us that this should be regressive. Right? The biggest burden should fall on folks in the lower end of the income distribution. And that's largely what we see. We don't see any effect for folks earning less than $20,000 a year. Right? And that's because those folks generally don't have employer-sponsored health insurance. The burden is falling on folks earning between $30,000 and $100,000 each year. Right? It's not falling on the C-suite. Right? It's generally less likely to fall on folks with a college degree. And the reason I'm super passionate about this work is when I take a step back, I fundamentally believe that a lot of the challenges we're facing as a country, a lot of the frustration that everybody has, is a function of income inequality. This is one of the major drivers of it. The next thing we did, and this hopefully will make sense afterwards, it didn't make a ton of sense going in, is we looked at mortality. Right? And it's not mortality from healthcare getting worse. It's linking onto this fact that we get a lot of dignity and purpose from our job. And there's a really big literature that I frankly wasn't aware of, that losing your job can be devastating for your health. Turns out it's actually mostly for men. That when men lose their job, we see about 1 to 300, 1 to 600 of them die within a year, generally from self-harm or overdose. If you look at hospitalizations around areas where a plant closes, you see bumps in opioid deaths, traffic accidents, and alcohol-related deaths. And we were seeing really big effects of hospital mergers on jobs. And the question was, did we see this? Right? And we can actually track folks very, very well. And what we see is that every hospital merger is leading to about an additional death per 100,000 in the area where the merger is happening. About 1 in 200 of the folks in our data who lost their job and got separated from the labor market died within a year, in our case, of an opioid overdose. Right? Because it turns out that a hospital merger that raises prices, that leads folks to lose their job, in the midst of an opioid epidemic, is a really bad thing. And this is a pretty provocative finding. Right? And so the question was, how do we rule out other things? So we can look at folks over 65. Was it something happening locally? It shouldn't break at 65. There was no effect on folks over 65. We can look at all deaths other than suicide and overdoses. We don't see any of that change. We can look at cancer deaths. Maybe it's something related to hospital quality. We don't see any of this. Right? The only change we see for folks in our data is that the folks who lost their job after a hospital merger were at low rates, but non-trivial rates, dying of overdoses. And what this lets us do, and my hope is, this for Claire and your colleagues, for everyone in this room, allows us to conceptualize the harms of hospital mergers differently. Right? So that a merger that raises prices by 5% is going to lead to $32 million in foregone income in the area around that merger. It's going to lead to about 200 job losses, $7 million less in federal income tax revenue. It's going to kill 1 or 2 people. Right? Economic losses on the order of about $40 million. And again, 20% of the deals that are getting through are doing this. Right? There's a deal in Terre Haute, Indiana right now that's going to raise prices by 30%. It's going to do way worse. Right, so the question is, why don't we see more enforcement? And what can we do? So the red zone for the FTC and the DOJ, right, where they say we've got a problem, is a change in HHI, this Herfindahl-Hirschman index, of 200 points. The average merger among hospitals in the US over the last 20 years is about 500 points. The average change in HHI among deals that the FTC investigated and pursued prosecution was about 3,500. Right? And the challenge is the FTC is just wildly underfunded, and they're tremendously capacity constrained. Again, it isn't that the DOJ or the FTC isn't amazing, they both are, right? But they're just limited. And so the question for all of us is, what sort of public policy makes this better? Right? And so one is just pushing for more funding for the FTC. Right? It's saying that rising health spending, hospital consolidation, right? It's this first order issue affecting our lives. I think the other is changing the way we think about rising health spending. It's a labor issue. Right? When hospitals merge, wages for nurses go down, jobs in the community go away, but it's also pro-business. Right? This is making industry less competitive. So it's thinking about the framing. It's state antitrust enforcement. I was with Lena Khan on Monday, and one of the things she talked about is it's really hard for the feds to get involved. Is there a doctor who's here? We're just going to pause for a little bit.
So y'all, we're going to pause for a moment and allow some recovery to happen, and then we will pick up in a moment, so just hang tight. A couple of you did ask where restrooms were, and they are through that set of doors at the far side of the room. There's also a set on the 4th floor, but in the meantime, we appreciate your patience as we take care of one of our participants. Thank you.